His prostate had been removed 14 months ago. Surgery went well. Pathology looked favorable. His surgeon said, "We got it all." At his 6-month check, his PSA came back undetectable, less than 0.1. He celebrated. His wife cried with relief. His surgeon said, "This is exactly what we want to see." Then at his 12-month check, something changed. PSA 0.2. His surgeon said, "Still very low. We will monitor every 6 months." He went home relieved, assumed 0.2 was nothing to worry about. Then he mentioned the number to his brother-in-law, a retired oncology nurse. His brother-in-law said, "Did your surgeon explain what 0.2 means specifically after prostatectomy? Did he explain the PSA nadir? Did he explain what biochemical recurrence is defined as after surgery? And what 0.2 relative to your previous undetectable result actually signals?" He said it was still very low. His brother-in-law said, "That is true. And there is significantly more to understand about that number than very low." After prostate removal, PSA monitoring works completely differently than before surgery. The thresholds are different. The trend interpretation is different. The response window, if action is ever needed, is different. And most men are discharged from surgery without a clear explanation of any of it. He brought those questions to his next appointment. His oncologist spent 30 minutes answering everyone. Today I am sharing what he learned, what PSA means after prostate removal, what the numbers actually signal, and what many men over 60 do not know about monitoring after surgery. Before we continue, quick reminder, this is educational information only, not medical advice. Post-prostatectomy, PSA monitoring requires individualized evaluation by your urologist or oncologist. Never interpret your specific numbers without professional guidance. Drop the word surgery in the comments for a free post-prostatectomy PSA monitoring guide, what the numbers mean and the questions to bring to your next appointment. Now, starting with the most fundamental thing most men misunderstand after prostate removal. Thing 1, PSA should be essentially 0 after surgery. And what that means? Before surgery, PSA had context, prostate size, free PSA ratio, density. After prostate removal, the context changes entirely. The prostate is the primary source of PSA in the body. When the prostate is surgically removed, radical prostatectomy, PSA should fall to essentially undetectable levels within 4 to 6 weeks. Most guidelines define undetectable as below 0.1 nanograms per milliliter. This is the PSA nadir, the lowest point PSA reaches after surgery. His brother-in-law's first question was critical. What was his nadir? He checked his records. His first post-surgical PSA at 6 weeks was 0.05. Undetectable by standard definition. His brother-in-law said, "Good. That tells us the surgery removed the primary PSA-producing tissue effectively." Now the question is what 0.2 means relative to that nadir, not relative to what PSA means in a man with an intact prostate. What does this mean for you? If you have had prostate removal, your PSA reference point is not 4.0 or any pre-surgical threshold. Your reference point is your post-surgical nadir. Every subsequent reading is interpreted relative to that baseline, not to population norms. Ask your doctor, what was my PSA nadir after surgery, and what is my current reading relative to that specific baseline? Thing 2, what biochemical recurrence actually means. This is the term his oncologist used that his surgeon had never explained. Biochemical recurrence, BCR, after radical prostatectomy is defined by most major guidelines as a confirmed PSA of 0.2 nanograms per milliliter or higher, measured on 2 consecutive tests. He had one reading of 0.2, not 2 confirmed readings. His oncologist said, "You are at the threshold. You are not yet at confirmed biochemical recurrence. But this is the number we watch most carefully because 0.2 confirmed on a second test changes our monitoring approach significantly." The American Urological Association and the American Society for Radiation Oncology both define BCR at 0.2, confirmed on 2 occasions specifically, because a single reading can reflect laboratory variation or residual benign prostate tissue rather than cancer recurrence. Approximately 20 to 40% of men who undergo radical prostatectomy will experience biochemical recurrence within 10 years. BCR does not mean cancer has spread. It means PSA is detectable at a level that warrants closer evaluation to determine the source and significance. What does this mean for you? If your post-surgical PSA has reached 0.2 or is approaching it, understanding the BCR definition is critical. 1 reading of 0.2 is a signal. 2 confirmed readings of 0.2 is a defined clinical event that changes your monitoring protocol. Ask your doctor, have we confirmed this reading on a second test? And what does a confirmed 0.2 mean for my specific monitoring plan going forward? Thing 3, PSA velocity after surgery is more important than the number itself. His oncologist said something that reframed everything. He said, after prostatectomy, I watch PSA velocity more closely than I watch the absolute number. A PSA of 0.2 that took 14 months to rise from undetectable tells a different story than a PSA of 0.2 that appeared in 4 months. PSA doubling time, PSA-DT, is the calculation that matters most after surgery. PSA-DT measures how quickly PSA is doubling. Slow doubling time, greater than 12 months, is generally associated with localized recurrence that responds well to salvage radiation if needed. Fast doubling time, less than 3 months, is associated with more aggressive disease behavior and may indicate distant rather than local recurrence. A landmark study from Johns Hopkins followed over 1,900 men after radical prostatectomy. Men with PSA-DT greater than 15 months had a 15-year cancer-specific survival rate above 94%, even among those with confirmed biochemical recurrence. Men with PSA-DT below 3 months had significantly different outcomes, emphasizing that how fast PSA rises after surgery predicts biology better than any single reading. What does this mean for you? If your PSA is rising after surgery, ask your doctor to calculate your PSA doubling time. You need at least 3 PSA readings taken over several months to calculate it accurately. PSA-DT is the number that tells your oncologist what the rising PSA is likely doing and where it is likely coming from. A slow doubling time is reassuring even when the absolute number causes anxiety. Thing 4, where a rising PSA is coming from matters enormously. His oncologist said, when PSA rises after prostatectomy, the first clinical question is not how do we treat this? It is where is this PSA coming from? There are 2 possible sources of PSA after prostate removal. Local recurrence, cancer cells remaining in the prostate bed, the area where the prostate was, that were not eliminated by surgery. Local recurrence typically produces slowly rising PSA with a longer doubling time. It is potentially curable with salvage radiation therapy targeted to the prostate bed. Distant recurrence, cancer cells that have spread beyond the surgical area to lymph nodes or other sites. Distant recurrence typically produces faster rising PSA with shorter doubling time. It requires systemic treatment rather than local radiation. Distinguishing between these 2 sources is critical because the treatment approach is completely different. Tools used to localize recurrence include PSMA PET scan, a highly sensitive imaging technology that can detect prostate cancer recurrence at PSA levels as low as 0.2 to 0.5 in many cases. A 2020 study in the Journal of Nuclear Medicine found PSMA PET detected recurrence location in 75% of men with PSA between 0.2 and 0.5 after prostatectomy, compared to 26% with conventional CT and bone scan. What does this mean for you? If your PSA is confirmed rising after surgery, the next question is not what treatment, but where is this coming from? Ask your oncologist, should we consider PSMA PET imaging to localize the source of my PSA rise before we discuss any treatment approach? Knowing where the PSA is coming from determines everything about what comes next. Thing 5. The treatment window and why timing matters. His oncologist said something his surgeon had never mentioned. He said, "One of the most important things men do not know after prostatectomy is that if salvage radiation is ever needed, earlier is better. There is a treatment window, and waiting too long closes it." Research consistently shows that salvage radiation therapy to the prostate bed is most effective when PSA is below zero point 0.5 at the time of treatment. A landmark study in the New England Journal of Medicine, the Radicals-RT trial, found that early salvage radiation at low PSA levels produced significantly better long-term outcomes than delayed radiation at higher PSA levels. Men who wait until PSA climbs to 1.0 or higher before pursuing salvage radiation, if it is ever indicated, miss the window where radiation is most effective. This does not mean every man with a rising PSA after surgery needs radiation. Many men with slow PSA DT and localized recurrence can be monitored carefully for extended periods before any intervention. Active surveillance after BCR is a legitimate strategy for many men. What it means is that the decision about whether and when to act, if action is ever appropriate, should be made deliberately and with full information, not reactively when PSA has already climbed significantly. What does this mean for you? If your PSA is rising after prostatectomy, have the treatment window conversation with your oncologist now. Not when PSA reaches a number that feels alarming. Now, ask, if salvage radiation ever becomes appropriate for my situation, at what PSA level would you recommend we consider it to preserve the best possible outcome? Understanding the window before you need it is how you make the best decision if you ever do. His oncologist covered all 5 things in one extended appointment. His PSA nadir was 0.05. His current reading was 0.2, at the BCR threshold, but not yet confirmed on a second test. His PSA DT, based on 3 readings over 14 months, approximately 18 months. Slow, reassuring biology. His oncologist said, slow doubling time at this PSA level with your pathology is consistent with localized recurrence if recurrence is confirmed. We are not at the point of imaging yet. We retest in 8 weeks to confirm or not confirm the 0.2. If confirmed, we discuss PSMA PET to localize. If not confirmed, we continue close monitoring. He said, I had no idea this was a 30-minute conversation waiting to happen. I thought 0.2 was just a low number. His oncologist said it may be just a low number, or it may be the beginning of a conversation we want to have early rather than late. Either way, you now understand what we are watching and why the timing of every decision matters. His brother-in-law had been right. Their